What I'm going to speak to you about is infections following prostate needle biopsy, and hopefully talk about an evidence-based approach to tackle this very common problem that we have. I don't have any disclosures that are relevant to this specific talk. I was on the AUA white paper from 2016 to 18, where we sort of brainstormed ideas on how to mitigate these complications. So some of the topics I'm going to talk about are from that work there. So we all know in this room that prostate cancer is common, most common cancer, non-cutaneous cancer in men, and the way that we render a diagnosis of prostate cancer is by prostate needle biopsy. We also know that more and more active surveillance is becoming par for the course for very low risk, and even some types of favorable intermediate risk prostate cancer. And as we are doing more active surveillance, biopsies play a critical role in this algorithm. And therefore, collectively, if we just sort of look at the US data, there's over 1 million prostate needle biopsies performed annually, and probably when we look at the global population, even more than that. So I want to use that as a framework and a background to really go through 4 objectives in my talk. One is some of the evolving challenges with transrectal prostate needle biopsy. Use that to dovetail into why has there been a resurgence in transperineal prostate needle biopsy, some data from large quality collaboratives in Pennsylvania and Michigan that highlight that information, and then to talk about a few trials that hopefully lead us forward. Before I jump in, just for those that do prostate biopsies, how many do them via the transrectal approach? And how many do them via the transperineal approach? Okay, great. So hopefully some for everybody in the room. So let's start with evolving challenges with regard to transrectal prostate needle biopsy. So all of us know transrectal prostate needle biopsy involves putting a probe in the rectal vault, piercing through the highly vascular rectal vault into the prostate, and therefore there's a risk of infection. There have actually been 11 studies that have sort of investigated the role of antibiotics perioperatively versus placebo, and have identified very clearly that you need to give antibiotics prior to prostate needle biopsy via the transrectal approach, with about a 50% reduction in the rate of infections. If you said, what prophylaxis should we be giving? This is the AUA best practice statement from 2020. And you can see that transrectal prostate biopsy is considered a contaminated procedure, and the recommended antimicrobial course is either fluoroquinolones or a first, second, or third generation cephalosporin with an aminoglycoside, and a single dose is recommended. Now, despite this, and this is some very nice data from Canada, Rob Nam published on this, which looked at hospitalizations after prostate needle biopsy and showed over a 10-year period a 4-fold increase in the number of hospitalizations from prostate needle biopsy, with about 75% of these being attributable to infection. And what's really the root cause of this? It's quinolone-resistant gram-negative organisms that have colonized into the rectal vault, with approximately 15 to 25% of men harboring such resistant organisms. Furthermore, there's ample data to show that many of these quinolone-resistant gram-negative organisms are actually multi-drug resistant. So therefore, just ubiquitously giving more intravenous antibiotics may not be the solution that we're looking for. So what's a summary of the problem? Infectious complications after transrectal prostate needle biopsy are increasing. Quinolone-resistant gram-negative organisms, particularly E. coli, are the culprits. I think simply giving a fluoroquinolone antibiotic may not be adequate for the future, so we need to think about some novel strategies and approaches. So in 2017, I was one of the persons that was part of this panel where we sort of strategized on methods to decrease complications attributable to prostate needle biopsy. And although we looked at all complications, the reality is a lot of the focus was on infectious complications. And we came up with this fairly long flow chart, which I've highlighted for you, but I'm just going to really highlight a few things that I think are important for practice. First of all, at the time of prostate needle biopsy, I think the single most easily modifiable factor that you can incorporate in your practice is to put povidone iodine or betadine into the rectal vault at the time of biopsy. There are 8 randomized control trials that have looked at this that have clearly highlighted a 50% reduction in infections simply by using povidone iodine at the time of transrectal prostate needle biopsy. Taking one step beyond that, there's the concept of antibiotic augmentation, for example, using a fluoroquinolone and then adding on some type of parenteral antibiotic at the time of the procedure. And then certainly the concept of rectal cultures, culturing the rectal vault, trying to identify quinolone-resistant gram-negative organisms, and then altering your microbial choice or antimicrobial choice accordingly in that regard. So what have we done at Penn State? We've incorporated several of these different variables. When folks come to clinic for a prostate needle biopsy, irrespective of whether it's going to be MRI or not, if it's a transrectal approach, they get a rectal swab that's done at that time to look for quinolone-resistant gram-negative organisms. Our base antibiotic that we use is quinolones unless they're quinolone-resistant, and then we use povidone iodine at the time of the biopsy. We have over 35 providers in our practice. We can achieve a 90% compliance using such a regimen. So it means it's highly applicable to a large group. And if you look at what are the results of it, our infection rate over the last 5 years is 0.7%, 0.2% sepsis rate. So I think we've really done a pretty good job in getting a handle of this problem. What are the positives of transrectal prostate needle biopsy? Look, it's really well tolerated. You can do it under local anesthesia. You can do it in your office. We've also recently looked at what about other complications, namely bleeding complications. And if you look at transrectal prostate needle biopsy, our data from the last 15 years shows 0.5% bleeding events that require you to come to the ED and come into the hospital, and 0.08%. So only 3 people in our last 15 years actually needed some type of ancillary procedure, and all of them were on therapeutic anticoagulation. What's the negatives of transrectal prostate needle biopsy? Look, infections still occur, and that's cost. That's cost if they come to the ER, it's cost if they get admitted, and it's certainly high cost if they need to go to the ICU. There's also sort of the cost of antibiotic stewardship. So if you look at the United States, there's 2.8 million antibiotic-resistant infections annually. So simply ubiquitously just giving one antibiotic and then just augmenting it with more antibiotics, especially as we have more people on active surveillance regimens, is really not a viable long-term strategy in this patient population. So I kind of want to use that as a framework to talk about why has there been a resurgence in transperineal prostate needle biopsy. So I'm going to take you back to this flow chart we put together a few years ago, back in 2017. And what I'd point out that's really interesting, in the far left-hand corner, we simply added transperineal biopsy. And admittedly, it was almost an afterthought when we constructed this white paper. But what we've seen over the last 4 or 5 years in the US, and honestly, we are trailing some of our colleagues outside the US, the UK, Europe, Australasia, they've really sort of more readily embraced this concept of Trexit, which is exiting the rectal vault and pivoting towards transperineal biopsies. So what I think is really interesting is I did a PubMed search on transperineal biopsy, and I did this just 2 weeks ago. And if you look at the number of publications in the last 5 years, it's almost 20-fold higher than what you saw in the previous 40 years, as shown in this picture. So I think that there is clear evidence that the transperineal route does have benefits with regards to infection risk. So this is from the EAU guidelines on prostate cancer, and they shared that if you look at 7 randomized trials, 1,300 plus patients, and you compare transrectal to the transperineal approach, it looks like the infection risk for transrectal approach is about 1.8-fold higher than what you have for the transperineal. There's also the thought that perhaps the transperineal approach may give you better sampling, particularly better sampling of the anterior zone of the prostate, as well as those aspects of the peripheral zone that are cheating up more anteriorly along the lateral horns. What's some data on this? So this is a paper out of Johns Hopkins that looked at their patients who had group 1 cancer, and they were on surveillance, and then they looked at what factors were associated with these patients being upstaged to group 2 cancer or greater. And of the variables they identified, one of them was that the transperineal approach was associated with upstaging, and they hypothesized that this was because of better sampling of the anterior zone of the prostate. So certainly, I think the conventional approach for the transperineal has been the grid approach, similar to how brachytherapy implants are put in, which is you put a grid right against the perineum, and then you can then target the prostate. But I would say a lot of the literature is now evolving a little bit more to the freehand technique. And so the freehand technique can use something called a precision point device. The precision point was actually developed by Matt Alloway. He's a urologist in Maryland. And I've actually used this. It basically just couples right onto a transrectal probe. The transrectal probe does have a longer crystal, because you need a longer crystal for the transperineal biopsies. And what you can see from this video right here is the device, the precision point, couples right against the perineum. It's got 2 cannulas that you can puncture right into the perineum. So you don't have to repeatedly stab through the skin. You use one skin puncture. And then you can do your local anesthetic, as shown in the diagram on the left, as well as do some of your other biopsies, whether it be apex mid-gland base, anterior zone, and whatnot. It's important to recognize, though, that transperineal approach using precision point is not the only way you can go here. So this is a video shared by Serge Ginsburg with me. He's at Einstein in Philadelphia. And what he basically does is he just takes a 16-gauge angiocath and just punctures it right into the perineum. And then in one hand, he has his ultrasound probe, and in his other hand, he basically, through the cannula, through the angiocath, basically does the prostate needle biopsies. So I think that takes a little bit more coordination. You have to get your two hands working together so that when you are moving your right hand, your left hand, which is doing the biopsy, or vice versa, is in concert. But it certainly highlights that you don't need to be dependent on one specific product simply to do transperineal biopsy. So this is some really nice work by John Davis out of MD Anderson, who basically said, well, what's the yield? If I did this via a freehand approach versus the grid-based approach, how did the two stack up against each other? And what he identified was the freehand approach had lower rates of complications from the biopsy. It had a shorter procedure duration. And interestingly, he also identified that there were perhaps higher mean number of cores with grade group 2 cancer that were identified. Now, most of us that do a lot of prostate biopsies have evolved to MRI fusion capacity. And one of the questions is, well, can you do a transperineal biopsy using MRI fusion capacity? And the answer is yes and no in some regards. So what I'm showing here on the left-hand side are a number of the different vendors of different MRI fusion platforms. And if you just said, well, what about that precision point that you just talked about? Actually, only 3 of the different platforms are actually compatible with precision point. So for example, we've been using at our medical center the Artemis system since about 2017-18. That is not precision point compatible. And I'd be the first to admit, when we do transperineal biopsies with the Artemis in the lithotomy position and that robotic arm, it's a little bit of a tight working space to do it. So I think that there is some areas of improvement that can occur so that we have better tools for all of the transperineal fusion platforms. Now, look, I'm going to be the first to say that all is not always rosy with the transperineal approach. And I think this is a very honest appraisal from the MGH group that basically published on local MRI fusion biopsies in the office, their initial experience with transrectal and transperineal. And what they identified very clearly was, sure, there was a lower infection risk. There was 1 case in the transrectal and 0 in the transperineal. But take a look at this. There was a trading of complications. The complication rate in the transperineal was actually a lot higher. More scrotal ecchymosis, more hematomas, several syncope episodes, and more bruising and bleeding. So I think we need to be cognizant that there may be potentially a trading off of complications. I think there are also some cost considerations that are important. So if you can do an MRI fusion biopsy in the office under local anesthetic, you have favorable cost considerations, whether that's via the transrectal or the transperineal approach. But if a patient has enough pain that you need to take the transperineal procedure and you need to put it in ASC under anesthesia or into a hospital setting, then the cost almost doubles. And I think we have to be cognizant that in order for things to be roughly cost neutral, how can we incorporate transperineal more into a local or office setting? So I want to share some data from Quality Collaboratives to give you a sense, and the arm raising in the room sort of mirrors what I'm going to show you, which is how readily within the US is transperineal biopsies actually being incorporated. So the first is from our experience in Pennsylvania. It's called the Pennsylvania Urologic Regional Collaboration. It's 13 academic medical centers all across the state. So the experience is very much slanted towards academic health systems. But what we've basically found is if you look at prostate biopsies done in our cohort, since about 2018, there's been a fairly high uptick in the adoption of transperineal biopsies, numbering close to about 30% at this juncture. What about the data from MUSIC? Well, that's the big Michigan collaborative. And if I showed you that data, I'm going to show you a tale of sort of 2 stories. One is practices that have implemented transperineal biopsy into their algorithm. And if you've implemented transperineal biopsy, the numbers look pretty similar to what I showed you for PERC, about 25 to 30%. But what about all the rest of those practices in Michigan that maybe haven't implemented transperineal biopsy? Far more modest numbers. Only about 10% of practices in all of music are actually using transperineal biopsy, really suggesting that the general urologic population is using TP biopsies far more than perhaps what we're discussing in some of the academic meetings. So one of the things we did was, in a collaborative effort between PERC and music, we actually queried a lot of the urologists on what are some of the barriers to adoption of this technology. And the benefits were, look, I think everyone understands there's probably a decreased rate of infection and potentially sepsis. I think there's this concept of improved cancer detection in the anterior zone, and the concept of antibiotic stewardship, that for many transperineal biopsies, you can maybe give something for skin flora, like cefazolin, or in some cases, not even give anything, just use a preparation in the local skin. But here are the challenges. Number one, access to equipment. An important thing to remember is that the probe for the transperineal biopsy is not the same as a transrectal, so you need to actually buy a new probe, and that's about $15,000 to $20,000. Patient pain and experience. So the ability that patients can tolerate having this done under a local anesthetic, and then inherently the learning curve for all of us in this room if you're not familiar with doing this approach. So I think all of this leads us to trials that kind of get us forward. I really want to highlight two trials that are looking at this, and I really think it's kudos to the investigators because I think these are meaningful data. So the first one is from Badr Mian. He's the PI from Albany Medical College. This is called the PRO-PC trial, and I just talked to him last week. The trial is complete. The results are with the statistician, and he hopes to present it at the AUA meeting this year as sort of a late-breaking abstract. Single-center trial, 568 patients randomized 1-to-1. Transrectal versus transperineal biopsy. It had to be done under local anesthesia, and you could do it whether you want to do an MRI fusion capacity or not. Didn't really matter. The critical thing was local anesthesia. Primary endpoints: rate of infectious complications, rate of non-infectious complications. Secondary endpoints: cancer detection rate, did the patients tolerate it, urinary and sexual function, and the cost of the procedure. And I think this trial should have a readout actually in the next probably 4 to 6 months. The second trial, which our center is part of, is a PCORI-funded study. This is a multi-center study. The PIs are Jim Hugh from Cornell, Mike Gorin, who's now at Mount Sinai, and they have about 9 or 10 other sites, including ours, that are part of this. Very similar design. 1,300 patients randomized 1-to-1 transrectal versus transperineal biopsy. The difference is all of these are MRI targeted, all are done under local. Now, notably in this study, all these patients needed to have a prior biopsy. So either they were MRI, they're on active surveillance because they have prostate cancer and they're on surveillance regimen, or they had a biopsy and it was negative, and now they're coming back for a repeat sampling. Endpoints, not surprisingly, not too different. Rate of infectious complications, and then because it's a secondary endpoint, it's pain, discomfort, anxiety, and detection of clinically significant cancer. So, conclusions: it's easily implemented practices can reduce infections for transrectal prostate needle biopsy. The TP infection risk is likely lower, albeit with some potential additional procedural challenges. Procedural infection is not the only factor when weighing TP versus TR prostate needle biopsy, and I think trials give us data, and data leads us forward.